Hey everybody, welcome back to Spot Check again. We're going to talk about Genoderms, continued this pathway here. We're on, if we're using Joel Spitz's book as a guide, we're on chapter 7. And this is going to be porphyria metabolism. I find porphyrias very challenging. So what are they? You know, they are actually metabolic disorders of heme synthesis. So these disorders lead to a buildup of porphyrin and its various precursors. And then understanding the heme pathway kind of clues you into what porphyria disorder we're dealing with. So here's an example below of the heme pathway. I think a few things to just kind of, take into consideration. We have some mnemonics and stuff, but kind of have a general idea where some of the subunits are. Are they out in the cytosol? Are they in the mitochondria? Also try to, relatively kind of keep an idea of what's going on. I think there's some more important fragments for dermatology that's compared to others in this puzzle, but I think that's a good place to start. A lot of times this can be overwhelming, and yet other things you're learning in dermatology. So this can be considered maybe lower yield, just learning the basics, what you need to know, bare bones stuff. But here's a couple of the big picture items for you. So ultimately, we know what heme is at this point. We know it's an essential molecule. It binds iron. It's made up of porphyrin, and that porphyrin component is actually what binds iron. Parts of this pathway are in the cytosol. Parts of the pathway are in the mitochondria. Porphyrin is basically essential for hemoglobin formation and function. And any disruption in this pathway can create significant problems, especially in the skin and especially in the nervous system. Here's another graphic detailing the porphyria synthesis pathway, heme synthesis pathway, as well as their related disorders. So a little bit of a cruder mnemonic here, but if you are really trying to hammer this home, those cruder mnemonics sometimes help. So we have porphyrias can go suck a fucking pee-pee. I know it's not spelled exactly how you'd think it's spelled, but use your imagination. The sucka-fucka-pee-pee is the mnemonic part of this. That's the succinyl-CoA, the ALA, or delta-aminolevolonic acid, the porphyrobilinogen, the hydroxymethylbilane, the uroporphyrogen 3, the coproporphyrogen 3, protoporphyrogen 9, protoporphyrin 9. These are the precursors. So this is where you're going to see your porphyrin build up in conjunction with the steps. So using that mnemonic we talked about in the last page, we can kind of help use the key parts of this mnemonic to isolate which of these subunits are in the mitochondria, which of these subunits are in the cytosol, or at least the products thereof. So the succinyl-CoA, mitochondria. So that's like kind of the first part of the mnemonic. And then the last part of the mnemonic is the PP part. So that's for the two P's at the end, the two P's that end with the Roman numeral 9. When the heme synthesis pathway does have a deficient enzyme, that's where the porphyria occurs. So here's a good overview, another one, of what enzyme is dysfunctional and then what porphyria that leads to. And you're going to see a couple of these names pop up again that we're going to go into further detail on. But, looking at the graphic, ALA synthetase, that causes X-linked erythropoietic protoporphyria. ALA dehydratase deficiency causes ALAD deficiency. Acute intermittent porphyria is caused by HMBS deficiency. Uroporphyrogen 3 synthetase deficiency causes CEP. Uroporphyrogen decarboxylase causes PCT as well as HEP. Coproporphyrogen oxidase causes hereditary corpoporphyria. And protoporphyrinogen oxidase causes variegate porphyria. Here's another mnemonic, and I know this it's your eyes are glazing over. I can see them. It's okay. It's okay. So try to use these mnemonics, or you could do your best and just take the L on what you don't know. But the mnemonic here, it's the order of the porphyrias as they occur. So these are the names of the diseases in respect to the enzyme or the pathway going top to bottom. So attempts at curing porphyria help vampires evolve. If you didn't already know, vampires are thought to be linked to early encounters with porphyria. So that's kind of where the legend comes from. But attempts A, ALD, at AIP, curing CEP, porphyria, PCT, help, HC or hereditary porphyria, vampires, VP, E for EPP. Okay. All right. So if you're just learning this from a derm perspective, then you're gonna really love basically 2 to 3 of these diseases. If you are learning this from the general medicine or normal medicine perspective, then in addition to using this, you might want to find a different resource. But there are some that are important to dermatologists, but not all of them. So these are also acute porphyrias. I want to also add. During these attacks, you're going to notice GI symptoms are predominant. So colicky pain, colicky abdominal pain, nausea, vomiting, constipation, hyponatremia. You may even see neurologic findings such as paresthesias, weakness, pain, seizures, psychosis, and then if severe pulmonary symptoms as well. And your first kind of clue to this would be a elevated porphyrobilinogen in the urine. Your precipitants for acute attacks of acute porphyria are listed here. Good mnemonic: begs for alcoholic drinks. So that includes barbiturates, estrogens, ergot, griseofulvin, sulfonamides. Alcoholic does alcohol. You can also lump in anticonvulsants with that, as well as dapsone. All right, so we kind of were covering some basics. We're going to go into some different porphyrias right now. There are acquired and genetic, so we'll go over some of that as well. X-linked sideroblastic anemia being the first, but is it actually a true porphyria? That's up for debate. But I'll have you know it does look almost identical to EPP. So here's an example of the disorders that we're going to go through. This is not the order of disorders as they appear in the pathway, more ordered for importance. So PCT, this is the one you've heard of. This is the medical school one. This is, when you think of a porphyria, this is kind of the prototypical disease. So PCT is from a urod or urogen decarboxylase deficiency. And you can notice that over on the right here, uroporphyrinogen decarboxylase is in the graphic. So it is the most common porphyria, equal in gender, autosomal dominant when inherited. Your features include skin ones here, delayed type photosensitivity with bullae, typically on the dorsal aspect of the hands. You'll also notice erosion, skin fragility, facial hypertrichosis, and hyperpigmentation. And then with GI symptoms, hepatocellular carcinoma can happen, liver hemosiderosis can happen because of hemochromatosis being concomitant in this disorder, and then noting that the hemochromatosis is common in this disorder, diabetes mellitus can also happen. So PCT is your prototypical porphyria, and as I talked about, the porphyrias were what was used to kind of, start the folklore of vampires. So think of a vampire, right? They're allergic to sunlight. That's why sun causes these bullae, scarring, and erosions. And to kill a vampire, you got to pierce its heart with a metal rod, and a rod is in the name of urod when you use the abbreviated version of that deficiency or that enzyme. So what can you do to help clue you in? Labs you can order: plasma porphyrin levels and fluorescence spectrum. You could do a 24-hour urine porphyrin level. That's a little cumbersome to patients. CBC, LFTs, iron levels, hepatitis panel can all clue you into some of the concomitant issues as well, as liver scan. And then urine screen, if you're, want to do the fluorescence wood lamp to a urine, you actually might notice that it takes on a coral pink color. Other labs you could do: skin biopsy can often help you if there's consideration of a porphyria. Oftentimes you'll want to combine that with a DIF to make sure that there's no other blistering or bullous disease that is happening in conjunction. You manage this with phlebotomy, that can be helpful, but typically dermatologists use antimalarials like Plaquenil, and trying to find out the causative agent. Is alcohol playing a role? Let's remove it. Is estrogen playing a role? Let's remove it. Is there a hemochromatosis consideration here that's causing this? Tackling that. Sun protection. If this is sun flares that are causing this, then you need to know that as well. I would also let you know that there are a couple drug-induced causes, and just for board's father, NSAIDs are considered to be a cause of a cutaneous porphyria, PCT. So keep in mind that things like naproxen can also be a causative agent, and that's such a benign over-the-counter medicine that it's easy for someone to take without being prescribed. Fun fact for you, fun and also board father here. So the Soret band, it's around 410 nanometers, causes porphyrins to absorb light, and then energy that's enters that molecular state of excitement where electrons jump up a additional level and then will then decrease back to their resting state, releasing their own spectrum of light thereafter. Do note that there's a generation of reactive oxygen species as well as free radicals that can then end up damaging the lipids as well as protein cross-linking. Now, there is two water-soluble proteins. There's, urobilinogen as well as coprobilinogen that can cause the blistering, and then lipophilic proto-based proteins can cause the cutaneous burning sensation as well as the edema and erythema. Variegate porphyria, so we do know that this is I'm going to abbreviate it, protogen oxidase deficiency. It's listed on the right. I've tried to say it 3 times, and we've edited it out 3 times. It's just easier for me, guys. I'm sorry. And then also, we know that this is most common in South Africa. There's an autosomal dominant component to this as well, but it presents post-puberty, 20s and 30s. There are drugs that can trigger this one as well. Barbiturates, estrogen, griseofulvin, sulfonamides. Infection can cause it. Fever, alcohol, pregnancy, and decreased caloric intake. Your key features here, again, you're going to get bulle erosion, skin fragility, facial hypertrichosis, hyperpigmentation. GI-wise, you're going to get colicky, abdominal pain, nausea, vomiting, constipation. CNS-wise, you're going to get peripheral neuropathy with pain, weakness, and paralysis. Maybe even central nervous system concerns like anxiety, depression, delirium, seizures. And then even this one can present sometimes with tachycardia and hypertension as well. Now, the key to here is variegate porphyria also presents with cutaneous findings. So that's important here. And you know that the buildup, if you have a mutation in the protogen oxidase, you're going to have buildup of protoporphyrin 9. Now, why is that important? Because your buildups, sometimes they'll say, hey, here's your disease, here's the mutation. The mutation's in protoporphyrin oxidase. Now, where's the buildup? In this case, the buildup, you'll see it in the mitochondria, or at least protoporphyrin 9 will build up in the mitochondria because the step before that is there. Now, PCT, which presents eerily similar, its buildup will be in the cytosol, right? Because you know that the enzyme affecting PCT is uroporphyrin decarboxylase. Labs to order, similar labs. You could also get urine levels of urine porphyrin levels, fecal porphyrin levels. This one, little more severe. Getting an idea of what's going on with this is important. You might, from a primary care perspective, you might end up referring to derm for initial diagnosis or at least concern. But ultimately, neurology will be taking the lead, as well as nutritionists here, making sure that your diet is appropriate. And these acute attacks are fatal. They can definitely be fatal if long-lasting enough. So that is the importance of having neurology on board. So in the last mnemonic, the PCT one, we were talking about how, vampires are afraid of the sunlight and they get stabbed in the heart with a metal rod. So here, variegate porphyria, we're going to talk about how starving vampires are drug addicts that are going crazy. Draw your own conclusions. I don't know any drug addict vampires, but if it helps, it helps. Now, like PCT, you get a lot of the same skin findings and GI findings, but the addition to variegate porphyria is the CNS effects. So that's where the vampires in this case go crazy, you know. And it can be triggered by drugs. Some of the drugs we talked about in depth in the previous slide, as well as starvation or dietary changes. Now, there is an allergic to sunlight potential here because, like we said, some of these wavelengths activate the porphyrians that settle in your skin, causing these bullae scarring and erosions. Moving on to AIP here. AIP is nice because there's not any strong derm findings for my dermatologic friends out there, but still important to kind of have an idea of because of the severity and such. Now, it is a mutation in the PBGD gene or enzyme. I'm, of course, abbreviating that, but if you look on the right, you'll see it. Porphyrobilinogen deaminase enzyme. It's listed there on the right. It is a cytosolic protein with cytosolic precursor buildup. And the key here is you're going to have GI pain, CNS findings, CV findings, and maybe even hematologic findings. Your labs will be largely the same because porphyrin levels will help clue you into exactly what's kind of going on. And then isolating the triggers that might be playing a role is important as well. And the triggers are largely the same. So neurology is going to be pretty important in this because there are some debilitating CNS findings in this. And these acute attacks, again, might be fatal or long-lasting. All right, moving on, we have ALA-D deficiency. So remember the ALA-D enzyme. This one's actually autosomal recessive, and it looks like AIP. It barks like AIP. It presents the same as AIP, which AIP presents similarly to VP without skin findings. Just kind of put it all together. So ALA-D deficiency looks like AIP, but rare. And really, the only way you're going to be able to find the difference is if they give you some sort of enzyme or buildup to help clue you in. So moving on to hereditary CP here. It is very similar to the last two porphyrias, so VP and AIP. We know that this is a coprogen oxidase gene mutation. Coprogen obviously being short for which enzyme? Think about it. That's right. Coproporphyrinogen oxidase. So I'm abbreviating them on the left, but keep in mind that they're not the full names. This is an autosomal dominant mutation as well, triggered by the same things. So keep those drugs in mind that we mentioned with VP and AIP, as well as the other findings as well. They all share the same management and very similar prognosis as well as the skin findings. HCP can actually have a delayed photosensitivity, so that's what kind of throws it differently from AIP and makes it more similar to VP. They're not the most predominant factor, and they're a little delayed, but they are still photosensitive. Ferrochelatase deficiency causes EPP, which we're going to talk about now. So EPP is a type of porphyria again, but this one causes a specific type of skin finding, and it's the distribution of the lesions. They are going to be more burning, stinging, and more of an erythematous plaque that weeps rather than like true thick blisters. And then after chronic exposure with UV light, you get this waxy, thickened scarring that can happen in all the sun-exposed areas. So that includes the nose, face, back of the hands, linear depressed scars, especially perioral and elliptical scars on the face. Here you're going to also see GI symptoms such as cholelithiasis, liver disease, and maybe even jaundice that the liver disease is so bad. EPP, you're going to get a lot of the same labs, and since this one has a strong gallbladder predominance to it, you're going to want to make sure that the gallbladder is fine too. If they're symptomatic, you don't have to do that unless they show the symptoms. Now, if you remember what's the enzyme, it's right in the top right, ferrochelatase, so EPP, ferrochelatase, that means you're going to have a buildup of protoporphyrin 9, and that you're going to have a buildup of that in the mitochondria, okay? This is a very very quick skin, so squick, I guess, quick skin reaction to UV light. And this has more long-lasting later effects, as well as the potential for severe liver disease. Now we're going to talk about sideroblastic anemia, which is X-linked. Remember at the beginning I said it's not really a true porphyria, but it's pretty darn identical to EPP. EPP being a mutation in what? That's right, ferroketolase. So sideroblastic anemia being X-linked, you're going to get the same manifestations, maybe even a few extras like anemic type, so lethargy, fatigue, shortness of breath, heart palpitations, and dizziness. The mutation itself that's mutated is allosynthetase. So that is actually the first enzyme here, the one that converts succinyl-CoA and glycine to aminolevulinic acid. CEP, this is another skin retaining disorder here. So this disorder is going to have skin findings. CEP stands for congenital erythropoietic protoporphyria. This is a mutation in abbreviated urogen 3 synthase gene. So if you look over on your right, again, you're going to see, where is it at? There it is, uroporphyrinogen 3 cosynthetase. It is extremely rare. It is autosomal recessive, which leads to its rarity as well. And this happens early in life. These other ones were happening, 20s, 30s largely. This one happens early. You're going to get immediate burning, photosensitivity, edema, erythema, vesicles, bullae, mutilating scars, all in sun-exposed areas with sclerodermoid changes. The teeth here are pretty interesting, and if you're curious, it's a good maybe clue. So your clues for this one, you're probably like, okay, I just learned about 8 different things, each with its own 12 syllables. How can I separate at least this one out from the others? This one is in kids. So if you have a kid that has a porphyria or porphyria-like symptoms, then hedge it's CEP. The other thing you can hedge on is if they show you a woods lamp with the teeth and they look red and brown. So that's a good helpful tip as well. There also is the chance of photophobia, ectropia, and conjunctivitis with this disease. Hemolytic anemia and splenomegaly also occur. So here's some good examples of the fluorescent woods lamp, as well as the pink urine that also shows up in this one, as it also shows up in PCT and most of the others as well. Dentistry actually is going to be involved in this one. Surgery is going to be involved in this one because a splenectomy might be needed. It does have a favorable lifespan, so keeping an eye on this one, making sure it's treated, can still provide a high quality of life. So big picture here, babies with pink diapers, awful disease. Skin, teeth, eyes, spleen, and blood are affected, and you're going to get blisters pretty rapidly at a young age. Another incredibly rare porphyria here is hepatoerythropoietic porphyria. This actually is a mutation in the urogen decarboxylase deficiency in that enzyme. Ironically, this is the urod enzyme. And you remember urod, we were taking vampires and stabbing them in the heart with a metal rod, and they were afraid of the sunlight in the very first one we talked about, which is PCT. So this enzyme is shared between HEP and PCT. However, this mutation in this type of disease presentation is rare, but also similar to CEP. So even though it shares the same type of enzyme as PCT, it looks more like CEP, which is one step above it in the pathway. You're going to have a photosensitivity that is severe, and it decreases as the age gets older, as well as changes such as dark urine, hemolytic uremia, anemia, and splenomegaly. Labs largely the same. Derm can help, but GI and heme should be involved as well. And the big picture here, HEP, CEP, largely similar. So extreme photosensitivity early at birth, dark urine, hemolytic anemia, splenomegaly, and kind of like diet version CEP. So remember, CEP also, red teeth, a little more severe, etc. So I got some review questions. If you feel like you got the most out of this video, right here is probably where you want to end it. I have some review questions that we can talk about here to kind of just solidify some stuff. So let's go through the heme synthesis pathway, right? Remember these mnemonics we got for you. So suck a fucking PP, and that one will help tell you product build up as you go through this. And you'll know that the beginning, the SUCC part, and the PP part help clue you into buildups in the mitochondria, and the rest you can assume is cytosolic buildup. Also do note, let's go through the enzymes real quickly since we know that the first mnemonic so well. We have ALA-S, ALAS synthetase, that is linked to X-linked sideroblastic anemia, not a true porphyria, but should be included. You can also have ALA-D deficient porphyria and the ALA-D or ALA dehydratase deficiency. Nothing we really talked about too in depth today. AIP not being a true derm porphyria, but still important. This is in porphyrobilinogen deaminase. CEP, the one with the red teeth, presenting in young kids. That's going to be a mutation in uroporphyrinogen 3 cosynthetase. PCT here is next, as well as HEP being shared with this enzyme. The enzyme is uroporphyrinogen decarboxylase, or UROD. HCP, or hereditary coproporphyria, going to be shared with the enzyme coproporphyrinogen oxidase. Variegate porphyria, going to be noticed with protoporphyrinogen oxidase. And then EPP, erythropoietic protoporphyria, going to be noted with ferroketolase. Another mnemonic here with the abbreviations, if you like the abbreviations, and then also highlighting there pretty in-depth which ones are in the mitochondria and which ones are not. Remember that mnemonic there for the accumulation. And then let's talk about which steps occur in the mitochondria and which porphyrias are associated with that. So I'll let you think about it for a second before I click right through it. Yeah, exactly. They're all listed in front of you. I made it easy. It's not like pick the one that's right. It's like they're all right, So these are the three enzymes and their buildup, these are the three enzymes and their disease that you need to be familiar with in terms of mitochondrial buildup. Cool. Do remember that most of these are autosomal dominant except for one autosomal recessive and one X-linked disorder. So continuing the post-test here, what is the most common porphyria overall? Yep, you guessed it, that's PCT. What porphyria is the most common in children? I know I made such a big deal about one of them being in children, and you're probably going to kick my butt, but there's actually a better answer for this one, and that is EPP. So EPP is technically the most common in children. Remember, this does not present with the erythrodontia. This has milder cutaneous findings. It's not as mutilating as CEP. Can happen in kids and be symptomatic in 1 to 6 year olds. If you see EPP in an adult, then you want to be concerned for a malignancy. So which porphyria is the most common neurocutaneous? Remember the vampire that is a crazy drug addict was the mnemonic, and that's the variegate porphyria one. Which porphyrias have no characteristic skin finding? AIP and ALA-D deficiency. Which porphyrias features erythrodontia? That would be, CEP and HEP. HEP being the rare cousin to CEP. What wavelengths is Tourette band? We talked about it. It's 400 to 410. What is the most severe porphyria? That is the kid CEP porphyria. Even though it's not the most common kid porphyria, it is the most severe, causing mutilating symptoms as well as high risk of GI, liver concerns as well. Which porphyrias have an actual risk of liver cancer? AIP, which remember doesn't have any skin findings, as well as PCT, which does, prototypical skin findings. An easy way to kind of help you with the PCT one is hemochromatosis is often considered to be, a potential trigger of porphyria as well. Here's some stuff we didn't quite talk about too much in depth, so it's good to talk about it now. We do know that the urobilinogen does kind of build up in the urine. It's water soluble, and it can fluoresce pink to red at 365 nanometers. And that's specific for PCT. You can also see in stool, more stool-like, that it would be coproporphyrinogens or coproporphyrins. That's important to kind of understand. What wavelength does plasma fluoresce in VP? And remember, this is plasma, not urine. There are lots of wavelengths being thrown at you, I know. This is 626 nanometers. Okay. So, and then which porphyria has gallstones? That would be the one with a predominant liver concern. I'm sorry, gallbladder concern. That would be EPP. So just a reminder here, some other key things, knowing which porphyrias present in infancy and childhood: CEP, HEP, EPP. EPP being a little more common, not quite as severe, and CEP being more mutilating, scarring, severe with chronic changes. Remember the ones that present in adulthood here, that's PCT, VP, and HC. Knowing which porphyrias are autosomal recessive helps, because if you understand the autosomal recessive ones, you can make the assumption that the other ones are autosomal dominant. So know that CEP, HEP, and ALD are the autosomal recessive ones. And it kind of makes sense. Usually your autosomal recessive diseases are a little worse than your autosomal dominant diseases by, just a hasty generalization there. So knowing that CEP is actually a pretty gnarly disease must be AR. And we know that HEP also is very directly related to CEP, even though it's a different enzyme. And that one's AR. So just that's a good way to help. And then you can make the rational assumption that anything else that we're talking about is autosomal dominant. Again, thanks, Marta, for what you do and making this PowerPoint. We can't do it without our awesome medical students. And thank you, Leo, for editing this.